This time I would like to introduce Dr. Cato Lorenzen, who is the chairman of the board and the visionary of the Montague Cobb Institute for remarks. Dr. Lorenzen.
Thanks so much. I just want to just say a few words. First of all, I'm very excited about the program that we have today, and because it brings together a number of people, a number of programs that we have great interest in. First of all, I'd like to express my gratitude to Esther Dyer and the National Medical Fellowships. We had discussions during the last year about how we could work together and partner to bring this issue about leadership in medicine to the fore, and sort of strategize a number of different ways, and had contacts with Bristol Myers Squibb and also the Robert Wood Johnson Foundation about this. At the same time, Joan Reede, who is a member of the Cobb Institute and associate of the journal, associate editor for the journal, also had this same concept that this is a crucial issue that took place, and we were able to marry these two different interests together in a very unique way here at the meeting. So this is of especially importance to me in terms of our ability to bring together really great people and great minds to be able to work and solve this problem. The Cobb Institute, just as a word, we're now entering our second decade of life. We've had some extraordinary meetings in extraordinary years. We have our next meeting, just actually looking backwards, we had a very large summit, the first national summit on the elimination of health disparities that was at the University of Connecticut. We obviously have this meeting. We have another meeting taking place in January in Florida. And then we're planning the second national summit on the elimination of health disparities, which will take place in October 2016 at the University of Connecticut again. So we have a great deal of programming, and this is a very, very important part of our core programs that are here. So I want to take this time to congratulate Dr. Morgan, who is the backbone of the Cobb Institute, for his great work in assembling all the pieces here and really moving the Cobb to the next level in terms of the work that he's done. So thank you, Dr. Morgan. And with that, I'd like to introduce Dr. Margot Lapointe, who is the Vice President for Research at Henry Ford Hospital and the Henry Ford Health System Interim Division Head of Hypertension and Vascular Research at the Henry Ford Hospital. Dr. Lapointe has been really great in terms of working with us in what's really developing as a new partnership between Henry Ford Hospital and the Cobb Institute. And let me just say parenthetically that I've been so impressed with the individuals at Henry Ford Hospital for their professionalism, their dedication to elimination of health disparities, and while our relationship is very nascent in many ways, I am extremely optimistic about the types of collaborations that we'll be able to have in the years to come. Dr. Lapointe.
Good afternoon, everyone. I'm delighted to be here, and I'm thrilled that you all have such a spectacularly beautiful day here in Detroit. The view of the river is wonderful, so I hope you enjoy your time here. As has been indicated, the Cobb Institute and Henry Ford Health System are going to develop a program whereby we are going to share the training of physician scientists in areas such as health disparities, social determinants of health, various behavioral interventions. And our public health sciences department has incredibly strong investigators doing epidemiology of allergy and asthma, childhood diseases, cancer, sarcoidosis, et cetera. And we've got both a prevention and behavioral intervention component to our research. I'd like to point out here we have Dr. Christine Joseph, who's the head of our Health Disparities Research Collaborative, and she's going to be the point person for helping to develop these programs between Henry Ford and the Cobb Institute. And also we have Chris Johnson, our chairman of Public Health Sciences Department. So these two individuals are going to be key. We look forward to developing our programs where hopefully we've got students coming in the summers to our hospital to work on key research projects that will be important for not only investigating health disparities in more detail, but also to provide training opportunities so that we can increase the number of minority physician scientists who are NIH funded and funded by other mechanisms. So these are two important goals that we hope to succeed in. So thank you so much for allowing me to be here. I appreciate it.
Well, thanks so much. Next, I'd like to introduce Dr. Esther Dyer, who is the President and CEO of National Medical Fellowships. Esther Dyer has been just an indefatigable leader of the National Medical Fellowships, and she has really moved the organization to new levels with her energy, her insight, her wit, her humor, and it's just been a great pleasure to work with her. And we are proposing with the National Medical Fellowships some new partnerships. This is part of these new partnerships, this meeting today, and so we're so excited to work with her and would like her to come up and say a few words.
Thank you so much. For many of you, National Medical Fellowships was part of being in medical school. We were founded in 1946 when there were no residencies for African Americans in Chicago. Since then, we've funded 30,000 scholarships, and today we can identify 17,000 physicians who are currently working and have findable addresses. But really what NMF is all about is not the numbers, it's really about the people. And it's about developing generations of leaders. And so I am really, really honored to participate on behalf of NMF with the Cobb Institute about also how we deepen and strengthen research as part of the leadership we need to change our systems in order to be responsive and in order to eliminate health disparities. And so one of the things that NMF does enormously well is it identifies talent really early. And so I want to just let you know that we have many of our alumni here represented. Joan, Reede, Cato Lorenzen, many others. Garth Graham's on the program. And many of whom have really been here outstanding leaders. And we are honored to participate today and as part of this program, but also to let you know that we currently give out about 200 scholarships a year. Of that number, many of them are service learning, where we provide mentoring and placement in a number of different partner institutions. And all of us are about what does this really mean? And a lot of it means that people end up learning what it is they need to know in order to go on their pathway to careers. Some of that started very early with the Kellogg Foundation, and many of our early scholars are still there in our program in Mississippi, and that continues today with the Aetna Foundation support. So I thank you very much. I know I've taken up too much of your time, but I do want to let you know that we're also very proud that 12 presidents, including the current president of the National Medical Association, have been NMF alumni. Thank you.
Thank you very much, Dr. Dyer, and all the speakers. The W. Montague Cobb Symposium and Lectureship was begun 10 years ago, and it has been a signature event at the National Medical Association Convention each year. We've been given the honor of having a plenary setting, an auditorium for our program, and the programs have been always on cutting-edge events and events that are interdisciplinary. I'm particularly proud of the program this year, first of all, because of the discussion we had this morning. This program just moves right in behind that discussion in terms of the pipeline in our medical schools and the dilemmas that we face with underrepresented minorities. And this takes it one step further in terms of those who have completed their training but need to look toward being leaders. Dr. David Satcher, of course, has been focused upon leadership in medicine for many years, and he indicates that one of the courses that he did not take in medical school was how to be a Surgeon General. And many of us have been thrust into positions of deans of medical schools and presidents, or even just the chair of the department in your local hospital, with no training whatsoever in terms of leadership. And so we feel that it's important to begin to focus upon that. And actually, Dr. Joan Reede, who is one of our Cobb Senior Fellows, as well as Dean for Diversity and Community Partnership at Harvard Medical School, solicited the Cobb Institute to maybe serve as a forum for this discussion today, and also wanted to focus upon those who are early in their careers and can give their perspective. So we're very excited about having Joan as the Cobb Lecturer. Our first Cobb Lecturer was also from Harvard, a gentleman, Dr. Augustus White, who spoke on cultural competency and has, of course, written many books on unconscious bias, and was one of Joan's mentors. So we're down to the next generation now, and without any further ado, would like to introduce the 2015 lecturer for the W. Montague Cobb Symposium, Joan Y. Reede, Dean for Diversity and Community Partnership at Harvard.
Good afternoon. It is good to be in a place where you can say good afternoon and people respond. Sometimes at Harvard, people don't quite know what to do when you say that, and they've not been trained in the call and response. So thank you very, very much. I'm so proud to be here. This is such an important part of the NMA and the Cobb Institute, and deeply honored. Randall is correct, as is Cato, that I contacted them because I was really interested in this topic of leadership, but in having you hear from the young leaders and the people who are in the pipeline. And as part of it, I was told that I needed to give a lecture that led into it. So deeply honored for that, but also deeply honored that I'll be a part of you hearing their voices. Where I want to begin is to talk about this concept of leadership and the importance of diversity in this leadership, but to think about why diversity is important. And I'm talking about three things here, about how diversity helps us to realize our values, how it helps us to address complex issues and problems that we're facing, and also how it enhances the viability, ensures the viability of our institutions. And when I talk about these realizing the values, these issues around equity, around justice, around inclusion, go back. They are part of the foundation of medicine. So if you go back to the Hippocratic Oath, in the Hippocratic Oath they talk about us as members of a society and our obligations to all patients. That's 5 BC. If you move forward to the Declaration of Geneva in 1948, they talk about, I will not permit consideration of age, disease or disability, creed, ethnic origin, gender, nationality, political affiliation, race, sexual orientation, social standing, or any other factor to intervene between my duty and my patient. Fundamental to who we are as professionals. If you look at the Belmont Report from 1979, which really followed an understanding of the transgressions of Tuskegee, and speaks to what we need to do and how we need to have safeguards within our research enterprise, it has three major components. One is about respect for persons. A second is about this beneficence and doing no harm or minimizing risk. But the third is about justice. And it states that ensuring reasonable, non-exploitative, and well-considered procedures are administered fairly and equally. Again, these issues around equity and ensuring that all parts of our population are able to get the benefits from the research that we do. And more recently, the Charter of Medical Professionalism from the American Board of Internal Medicine, 2002, talked about three fundamental principles in medicine: patient welfare, patient autonomy, and this principle of social justice. This idea about justice and being equitable also shows up in the Institute of Medicine Crossing the Quality Chasm report from 2001, where it talks about healthcare systems and what needs to be in place if we're going to have an excellence in our healthcare system. They talk about healthcare systems need to be safe and effective and patient-centered, timely and efficient, but also equitable. So when I turn to my own institution, how does this show up? I've been doing diversity at Harvard Medical School or diversity work for more than 25 years. And a few years ago, we added diversity, or the concept of diversity, to the mission statement of Harvard. So a change from doing diversity, which is a nice thing to do, to doing work around diversity and diversity inclusion is fundamental because it's part of the mission of our school. And it's been further described and defined by our dean of our school, who's moved it to a place now where he states that Harvard cannot achieve excellence in teaching, research, and service unless there is diversity. That Harvard cannot be a world leader unless there is diversity. And that diversity is required. Diversity of individuals must be involved if we are to change the culture of Harvard such that it can move forward in the future. So when we talk about this issue of diversity, oftentimes we talk about these traditional forms of race, ethnicity, gender, more recently sexual orientation or ability and disability. But I want to put forward that there are multiple dimensions of diversity, of culture, of the environments in which we've grown up, our values and our preferences, the relationships and the networks that we have, and that all of us bring all of these components of diversity to the table. For me, as an African-American woman, I find it fascinating because sometimes you feel this push and pull. You go into meetings and you have to figure out, today, am I representing the blacks in the room or am I representing the women? Which part of me? And this concept of intersectionality, that I am all of this, is not addressed. Important as we talk about this holistic admissions, because we've addressed some of this with our medical students in this concept of holistic admissions, and it's more than a number, it's more than a grade, it's more than a score. And now we're starting to talk about this in graduate medical education as we're looking at our training programs and the debacle that's out there in terms of our residency programs, looking at a score and thinking that that can determine who can be the best resident. So we're talking about holistic admissions for graduate medical education. What we're not doing is understanding that it's not just about entry. How can these individuals come into our organizations and bring their authentic and whole selves so that when they arrive, the institution is able to gain the benefit of all that they are? For me, it's when I stand in a room and they'll say, you know, Joan, this is wonderful, you know diversity. And I'm thinking, am I a pediatrician? And did I do child psychiatry? And do I have 4 other degrees? Maybe I know some other things too. And they put us in boxes, and then sometimes we allow them to put us in boxes. They don't get the full benefit of what we have to bring, and we don't get the full benefit of what we're able to offer. Diversity in addressing complex issues, and many of you know the work of Scott Page, and he talks about diversity as we're dealing with these complex issues in our society, and this toolbox that we can unpack, and this bringing together this diversity of perspectives, of interpretations, of heuristics, or how we solve problems, and the models we build are required if we are to address complicated problems and issues. Diversity of thought, And if we think about the complex issues we're suffering or dealing with today, as we think about research and building diverse research teams, as we think about research, and are we including all populations? Are women there? Are people of color there? As we think about diversity in education and training and the serious issues that we're addressing today, as we expand our medical schools, who is coming into our medical school class? To what extent does it represent our population? To what extent are opportunities available to those of us that I call, like myself, the multi-generational Americans, the Americans whose history includes slavery in their family? Are we a part of this process? Are we being left out of the process? Are we training and educating students and residents who are going to be able to deal with the diverse populations that we have? As we think about patient care and cultural competence and our patients getting the care that they need and quality care, health outcomes and health disparities and how it's disparate across different populations, and our real societal obligation in a pluralistic society to serve all, again going back to our values. Complex issues that are mentioned in multiple parts of this meeting. You know, we've been going down this road in medicine and medical education, and times are changing. It's a great time of change. For the road ahead, I'd like to think of it as closed for repairs. The old will no longer work. As we think about changing delivery systems, who ever thought we'd be talking about Walgreens and CVS delivering health care? Changes in the practice of medicine as we talk about personalized medicine, but personalized medicine for whom and how? As we talk about things such as ICD-10 and changes that are coming down the pike in just a few months from now, and how prepared are we for those changes? Changes that are going to be about changing the measures of how we're performed, and we don't have the systems in place. Changes in the relationships among the players, the stakeholders in the system. So we think about our federal government and ACA, part of a conversation earlier today, our states and those who brought it on and haven't brought it on, our local governments. When I think about the city of Boston, where the mayor and the Public Health Commission is asking our academic health centers, what are you doing to eliminate disparities in our community? The local governments are weighing in. Insurers, people who are in the exchanges, our healthcare organizations and the safety net, and their relationship with government as dish payments and uncompensated care are going away in many places. Our safety net organizations that are themselves changing. So I was recently reading about Charity Hospital, Charity reopening with a new name and an expanded role, and will it take care of the same population? What is going to happen to those individuals? Providers are changing, and this interprofessionalism, something that's important, but what is our role as physicians? Patients having new roles and new places, and patients who were once denied access, having access, but not being able to find a provider for that access. Changing times. So for me, this is an exciting time. This is a time when new systems are going to have to be built, and how can we be at the table? Not after everything's been determined, but at the table deciding what needs to be determined and how resources are going to be allocated. Viability. Our institutions have human capital. We bring human capital, social capital, intellectual capital. And what happens when you don't recognize the full wealth of resources that we represent and that's left behind? And our organizations cannot afford to do that. As we talk about time of scarce resources, is it efficient or effective to not take advantage of the full capacity that we have to really move our organizations towards achieving their missions? And then the changing demographics. You know, in 2012, there were 25 states in DC where the population was more than 40% minority. There were 13 states in DC where for the greater than 50% of the children under age 5 were minority. We know that by 2050, 2060, over half of our population will be minority. If we look at these issues and people talking about immigration, 13% of our population were born elsewhere. As we move forward to mid-century, it's going towards 19%. We sort of talk about these immigrants as though they're not a part of the fabric of the United States. The immigrant children are the fastest growing population. 25% of the children living in our country live in an immigrant family. And what we need to recognize is that 88% of those children are US citizens. So as we talk about them as being different, they are us. We are them. US physicians, long-term underrepresentation of blacks, Hispanics, Alaska Natives, Native Hawaiians, Native Americans. Academic medicine, similarly, lack of representation, poor representation. I've been doing this work for a very long time. For me, as I see this percentage here, the most striking thing for me is that this percentage made a huge jump after the Grutter v. Bollinger case with the University of Michigan, because they changed definitions. And it reminds us of the fact that as we talk about these issues, we're talking about social constructs. And there's all sorts of things you can do if you change a definition. But the truth of the matter is there's not enough of us there. At the same time, in this particular meeting, it has been amazing to see the pioneers, the individuals who, despite these low numbers, have set a stage for the rest of us to be here. The leaders, as you saw the Surgeon Generals, and you hear about Regina Benjamin, you see individuals such as David Satcher, you see individuals who've held roles such as David Satcher, Lou Sullivan, Dean Gracia was here from the Office for Minority Health. You see leaders in places such foundations that we never saw before. You have Risa Lavisa More at Robert Wood Johnson and Bob Ross, who's at California Endowment, Garth Graham, who sits here, who's with Aetna Foundation. Major changes in terms of people in leadership positions. If we look at government and NIH, we have individuals who are now directors of institutes. Early on, I never thought I would see a director of an NIH institute in my life who would be leading those things, particularly people I went to college with. You know, I look at Griff and I'm like, my goodness, that's not what I thought was going to happen when we were at that party. But they're in leadership. I look at people like Vivian Pinn, who have stayed the course for so very long, who showed us how to be a leader in the academy, who showed us how to be a leader in government, who showed us how to be a leader in this association, and has mentored so many of us, opened doors for us to be where we are now. These leaders have made strong strides and great changes, but I ask you to think about who is coming behind. Who is the next generation? So I'm going to give you a small example because I find this striking, and there's a wonderful forum that's going to be offered tomorrow that really deals with the pipeline, and particularly around African American, about black men, black boys, critically important. But it's not just that end of the spectrum where there's a problem, at the other side there's a problem. So here, these are from some AAMC data that show 2004 and 2014 faculty numbers. So there has been an increase. In a 10-year period, there is 150 more black male faculty. And there is 828 more female faculty. Seems quite inadequate when there are 17 more accredited US medical schools. If you look at the female faculty, you can say, well, there's an increase of about 50%, but now we're at 161 female full professors. So if you distribute them across the United States, we have just about enough for one female full professor per medical school. This is a problem. And if you look at what's happening to our black men, we've gone from 278 to 360 full professors. Sounds good, but look at the pipeline behind it. And associate professors over a 10-year period, only 16 more black associate professors. That's the pipeline towards leadership, a critical problem. So it's not just this idea of entry and getting people in. Are we retaining them? Are we advancing them? Are they moving forward? These are individuals who are pioneers. Think about yourselves. Think about the people who've come before. Pioneers who need to be more competent on the job, be able to fit into the organization, make others feel comfortable with your difference, deal with other people's preconceptions, questioning whether or not we can do the job or why we're there, and then asking us to serve on every kind of committee possible so there can be representation, and then not count that service towards advancement or promotion or really helping the institution to be successful. Being involved in recruiting and outreach. Pioneers have paved the way for people like myself to be here today. But what's the toll on those individuals? And we need to move beyond pioneers. What happens to individuals in our organizations when they're faced with these kinds of challenges and structures that are not only not welcoming, but structures that are biased? This is from some literature from England, some qualitative studies looking at the legal profession and women in the legal profession, but it pertains here. Individuals who enter an organization and become a part of that organization in ways that perpetuate the problems that we've had, and then those few individuals like the ones I've mentioned who's transformed them. Think about the push to assimilate, to say, I want to dress like you, I want to look like you, I want to have the same hobbies as you. How we're asked to compromise on our priorities between our work and our personal life. The playing the game and the stress of playing the game of always trying to figure out ways, how can I be visible? How can I be noticed? How can I prove that I have value versus the organization understanding and accepting the fact that I have value? The location relocate. Think about the individuals that say, well, it's not working here, I'll try over there. And they just keep moving because that full diversity, that wealth of what they bring is not recognized by the organization. And then the people who leave. And I think some of what we see in those data that I showed in terms of black faculty is because people have left. They're not willing to stay the course because it is so hard. And then we have those who can transform. So what are some of these barriers to our achieving diversity? Some of them are at the individual level. There's constraints that we have ourselves. It's the resilience to stay the course and to deal with these issues. But are we adequately prepared, and do we have the opportunities put before us, and do we have the resources to be successful? Some of it's our society, the politics, the economics, the culture that we reside in. This is not a minority-friendly or a diversity-friendly society. You know, it's interesting. I remember in my institution, for some of the people who talked to me after Obama was elected president and came to me and said, you know, Joan, isn't this wonderful, because now as a nation we've arrived. And these issues around diversity and minorities are resolved, okay? He was elected president, but did you read what was said as he was elected president? That undergirding of bias and discrimination, of stereotyping, of resistance to change still exists. But I want to also talk about the organizations that we enter, because all too often we think about how can I fix this person, when it's the organization and the structures of that organization, the policies of that organization are where we need to spend some of our time. So our office, my office at Harvard Medical School, is called the Office for Diversity and Inclusion, putting the words together, so that my work is not about how do I change the numbers at Harvard, although we've changed the numbers, but how do I include diversity across all aspects of the organization. All too often in our institutions, we have our organization, here's our mission, here's our goals, here's how we do our business as we strive in academic medicine towards this excellence in research and teaching and service. And then we have our diversity programs off to the side. They're not embedded. They're not part of the structure. And all too often when we look at them, the only thing we count is did the numbers go up or down? And think about your institutions that celebrate an increase in number. When someone says, you know, we have 100% more black faculty than we had last year. And the next question you should ask is, well, how many did you have last year? Because they went from 2 to 4. Okay? And when you look at the 4, you don't even know if they include the 2 that were there last year. Okay? So we have been forced into this place where we're looking at numbers that we don't really understand what's going on within our organization and don't know where to pinpoint interventions. if you think about the organizations and thinking about them moving along a continuum from early stages where they talk about these exclusive or passive clubs, these clubs that are really based around the founders and their views and their values, and places where it's sort of if you have to fit in that one culture or one style to exist, when you try to bring diversity into that place, they don't get it. They don't even know why you're there. And moving along this continuum towards the pioneers that I spoke of, to having a critical mass, to actually moving towards a place that's not just welcoming, but where diversity is included. A transformed organization that's able to recognize that full array of benefits that can accrue from having diversity. So how does diversity move in so that it is embedded, it's included, it becomes a part of the structure of the organization? Our programs become part of a structure of an organization. They're not viewed as you talk here about pipeline programs and these other kinds of things, they're not viewed as something that's nice that you do on the side, but organizations understand that they are imperative for the viability of our profession. And then how do we build the tools so that we can monitor what's going on and move beyond just counting numbers? So I'll just give you a little bit of the data. I have a research team in my office, and these are the names of my sort of research individuals who do much of this work. And what we've started to understand is that connections and how we're connected really matter. That all too often we feel isolated in our institutions and organizations, and how we are connected has an impact on our productivity, it has an impact on our advancement, and it has an impact on our retention. So one of the measures we use is something called REACH. It's looking at co-authors within an organization and the co-authors of co-authors. So it's starting to see who do you work with, how are you connected, how visible are you within the organization. As we look at this sort of issue, what we find, and this is within Harvard, and this work was done there because it's one of the few places where you have 12,000 faculty in one institution, so that the N is not a problem. Think about all the studies that we would tell you more about what's happened with minorities, but there's not enough of an N in the cell size, so I'm only going to tell you what happens with the whites, right? So this concept of reach or the connections is lower for women than it is for men, women in the blue, across all age groups. It's lower for blacks, Hispanics, and Native Americans than it is for whites and Asians across all age groups. So this connectivity. But what did we find? Does it make a difference? We looked over a period of 4 years and said, does it matter that our reach, our connection is less in our institution? And what we found, if you divided our faculty into quartiles, is those in the highest quartile at the instructor level are 3 times more likely to be promoted. That's if you take in the number of publications and the H index and where they trained and all of these other kinds of things, all of your demographic variables, how they're connected within the organization makes a difference in terms of the advance. 3 times more likely from instructor to assistant, 2 times more likely from assistant to associate professor. Connections matter, and we are not as connected. When we looked at attrition and leaving the organization, those with the highest connections, 25% less likely to leave. So as we start thinking about programs and what we need to do within our organizations, how are the individuals actually included within the organization? A little bit about programs, and I'm only going to talk about 2 of them here from our office, because what I'm often told is this work is too hard, or it costs too much money, or you can't do it. And so I'm going to give you 2 examples. One relates to a young woman, a resident, I think was a radiology resident, who spoke yesterday and talked about opportunities to explore different kinds of career paths. And here I want to talk about a visiting clerkship program. And then the second thing I'm going to talk about is a fellowship program that's for training leaders, called the Commonwealth Fund Mungan Fellowship in Minority Health Policy. Both of these programs are built on a set of principles that we have, that we look at careers as moving from one part of the country to the other. Lots of ways to get there, lots of paths, lots of stops along the way. There's not one right course, and how do we take that into consideration? How do we have a continuity of efforts as we think about the work that's going to be coming out of the NMA and AAMC and others who are partnering around our young black men? and moving them into the pipeline. That's not enough. It doesn't just stop with, can we get them in medical school? Can you get them in residency? Can you move them in other positions? It is a continuum of efforts, and given that I'm a pediatrician, it's a continuum that sort of starts in utero, but that's a different kind of issue. Consistency of effort. We start programs and we end them. The funding isn't there, so we just start and stop, start and stop. And we expect communities to stay with us. This importance of collaboration across institutions. Again, this issue of diversity, diversity of thought, diversity of perspectives, diversity of access coming to bear. Doing things that are different, not doing the same old thing, being creative. Communicating for me as we do this work, and understanding that the generations today communicate in a very, very different way. So I'm much better than I used to be, but a couple of years ago, I remember I sent my daughter a text, and what she wrote back to me was, "Who thought you could figure it out?" Okay? So they communicate in a very different way. As we're trying to create change and these new leaders and bring people in, we're going to have to also change what we do. Consideration of these multiple dimensions of diversity and not asking people to decide which box you want to be in today, and a consistent commitment. So as we think about this commitment, this is a visiting clerkship program. And early on in my tenure at Harvard, looked at when minority faculty decided they wanted to go in academic medicine, and a third was in college, a third in medical school, and a third post-medical school. But that transition between medical school and residency was critically important in terms of providing exposures. And so started a program where we support students being able to come to Harvard and do rotations in any area that they like, where they're provided mentors, where they're given the funding, because our students, given their debt load, cannot afford to pay for housing in Boston and transportation to Boston and for housing where they are. What you see here is that over 1,000 students have come through the program. They've come from multiple medical schools, and the reason you see 151, greater than 151, is because our medical schools keep changing their names and their affiliations. That consistently more than 10% every year match to our programs at Harvard, but many have ended up on faculty. So again, this continuity, this continuum, this effort that goes on. When I first started this, I remember some of the hospital presidents and others coming to me saying, "We've been doing this for 5 years, Joan, and I don't see faculty." And I'm saying, "You were talking about medical students." It takes a while to get there. Continuity of effort. The second program is a Commonwealth Fund Fellowship in Minority Health Policy, really born out of the Commonwealth Fund and Karen Davis and her participation in healthcare reform pre-Obamacare. And what she talked about was coming to these tables where they would be talking about the social determinants or vulnerable populations, and looking around the table, and the populations that they were talking about were not there. There wasn't representation, and came back to me and said, "Is there a need for diversity leadership around public health and health policy?" And this is a program that was formed with considerable consultation and input from multiple individuals, from Marilyn Gaston to David Satcher and many, many others. But over that time, you can see the vast majority have been women. It's a program where we pay for a degree, an MPH or an MPA. It's a program that has these sort of skill sets that you would think that you would need if you were going to move into a leadership position. It's a program that also says as you move into leadership position, you have to be able to work with community, where community is, to have this respect for community and community guidance, that it has to be about advocacy, and it has to be about creating change. These are some of the things that you read about in the leadership books, and they're important, but there's another component of this that I think is equally important. Our younger faculty, our fellows, our young physicians need sponsors. They need people who are willing to open doors and to vouch for them. They need mentors and networks, developmental networks across multiple disciplines and in multiple spaces. They need a community of support. All too often, they're entering spaces where they're isolated. If I think about myself and my career, I think about the individuals now who I turn to that I consider my supports, the people that I call on as I'm dealing with the challenges within my organization, when I have my self-doubt, when people are saying things that I just don't get. I need safe spaces to have conversations about, do you see just what happened? Safe spaces, as I think about our fellows and we think about Black Lives Matter and the deaths, safe spaces where we could come together and sit in a room and be able to cry as women who thought about our brothers and our children, and for me, my grandchildren. Where can you have those conversations? Because we are dealing with our personal lives as we deal with our careers and we deal with our organizations. They need resources, real resources, not pat on the back, this is nice, but real resources. And they need to be challenged to understand that they can do more and be more. So what has come out of this program? This is one program. 94% serve on national or federal committees, 73% invited for interviews, TV, radio. The majority have published, all are engaged in policy or public health or research or service around vulnerable and minority populations. And 78% have academic appointments in medical schools or School of Public Health. So these are individuals such as LaQuandra and Alden that you'll hear from Joe Betancourt, who's one of the Cobb Fellows, from some of the other fellows here, such as Kim. These are individuals who have moved into spaces where they've made a difference. The head of the Indian Health Service, the Commissioner of Health from Massachusetts, placing people in positions, excuse me, where they can create change. So as they do this, so they're moving into these same organizations that are not necessarily ready for them, that are along this continuum from these exclusive organizations that are sort of saying, why are you here? To the organizations that are saying, isn't it wonderful that you are going to be the first? But then that means you're a pioneer, and what does it mean to you, and does the organization understand it? And they need more than one pioneer. Where there starts to be a critical mass, but how do you build on that critical mass, and how can the organization use that information, that knowledge, that diversity in the critical mass builds? And how can it push itself further as it moves down the continuum towards being inclusive? So what I say is the time is now and the choice is ours, and borrowing from Gandhi, we must become the change we wish to see in the world. That this is not the time to wait for others to create leaders. It's up to us to create the leaders, to support the youth that are coming behind. And so when I call them youth, you understand what age bracket I'm in, because youth begins at an early age, but it continues on up. But how do we take care of those who are coming behind? How can we serve as mentors? How can we serve as sponsors? When they knock on your door, when they call you up, when they send you an email, respond, listen, connect. Connect them to your networks and help them to build their own networks of support. How do we start to understand the context, the environments in which they work, the organizational and the disciplinary context that help determine what's needed to be successful or to move ahead, and how do we build an evidence base that can challenge the beliefs and the myths about how our organizations actually function, how excellence is actually achieved, and how do we take responsibility for developing metrics that move beyond mere counting? How can we hold organizations accountable? How can we look at holding our professions accountable for diversity and advancement of diversity and leadership? How can we use our influence and our positions to make sure that those organizations that can change other organizations are doing what they should do? So for me, it's thinking about LCME and medical education, and what are the accreditation rules that they have? What are the rules and regulations, ACGME, all of those kinds of things? Where can we have a voice and be at the table to change things such that this diversity and this next generation can rise to the top? And this issue of interceding, this issue of being present and recognizing the youth that are around us. I would challenge everyone in this room, as you go back to your home institutions, to think about the 3, 4, 5 individuals who are in the pipeline who are ready to be able to be moved forward. Identify them and support them and connect with them. As your institution is going through the sorting process and selecting who should be moved forward, make sure that those names are present. Stand up for those individuals. We're at a crossroad. Our health system is changing. It's in a time of transformation. It needs to be informed by our values and the value of the people who are coming behind us, guided by a new kind of vision that is inclusive, secured by a vigilance, because sometimes we get comfortable because we think we've moved ahead, but it is so easy to slip back. Our voice must be ever present. We should be strengthened by our victories, but we need more. So moving forward, there's a call for new leaders. The real voyage of discovery consists not in seeing new lands, but in seeing with new eyes. We need new eyes. Thank you. Thank you.
Thank you very much, Dr. Reede. That was exactly filling the prescription and setting the tone for our program today. We have time for maybe 1 or 2 specific questions regarding Dr. Reed's presentation before we embark upon our panel. Dr. Bright?
There was an inordinate number of African-American men in the assistant position. Could you talk a little bit about, what are the obstacles that they might be facing in that position and the transition of moving from assistant to associate?
So I think there are a few things in here. One, I don't think we adequately understand what the obstacles are at that level. If I think about those from my own institution, it's being recognized for the work that they do. Oftentimes they're engaged in work that involves community or other kinds of research that are not recognized by their institution. Those are the individuals that are called on, can you serve on this committee or can you do this or that? That's also not recognized by our institutions for advancement. And as they're being asked to do that, they're being asked to take on more patient, on a larger patient load. And as you take on this larger patient load and you do this service to the organization and community, you then don't have time for the scholarship and the other kinds of things that are needed. And as you're doing all of this, you have this burden of this bias and this system that's in place and these structures that you're always trying to overcome. They talk about, the literature talks about diversity taxes. They are ever present. They don't just all of a sudden show up at one time. They're cumulative. As these individuals are trying to work through these types of issues, they're burdened and they're tired. And oftentimes they leave. Or they say, maybe this is what I'm supposed to do. Maybe I'm not supposed to be reaching. Maybe I'm not supposed to advance. Maybe I'm not supposed to continue to move forward, and they have a system around them that says that that's okay. So I think there's a lot going on. I think we need to understand it better. But as you look at those numbers, in 10 years, 150 black males, 20 years, 300, this makes no sense. I think for me, this is a dire emergency. We need to understand it better, but then we need to do something about it.
Hi, Dr. Reede. My name is Dr. Melissa Walker, and I'm standing as an alumni of your visiting clerkship program from like a few years ago. But I do want to say congratulations on 25 years and that the program truly changed my life. But on your numbers that you gave, and you were talking about the emergence of the new medical schools, I wonder if you're taking in consideration in your numbers the osteopathic schools, which are developing in enormous numbers. And having gone to osteopathic school, I know that there is a shrill minority of faculty and students in the osteopathic population. So I wanted, first question is, did you take those numbers into consideration? And the second question, as the National Medical Association, what are we doing to try to influence the osteopathic medicine field as far as taking in minority students and faculty?
So these are data that I pulled from AAMC. So I can't tell you to what extent osteopathic, allopathic. My sense is these are allopathic numbers that you're seeing here for our U.S. medical schools. The interesting thing about diversity is it doesn't matter the field, the discipline. There is a need for more diversity. So if I want to look at osteopathic schools or allopathic schools or dentistry or nursing or any kind of profession, there is a dire need for diversity. And if we look at faculty across those professions, even more so. If you think about dentistry, it's just ridiculous. They need faculty, period. But if you think about our dental schools, we have dental schools with one or no minority faculty.
My name is Dr. Mike Lenore, past president of the National Medical Association. And I also serve as chair of the clinical faculty at the University of California, San Francisco, and have been a full professor in that system. And everything you say is very true about how you support faculty. And there are success stories at Duke and Harvard and Connecticut and other places. But there are hundreds of schools across the country where we can't even set the table to get faculty. And I know in San Francisco, the issue of diversity seems to have completely gone away. There's nobody encouraging black faculty. They like to say they have it. And I serve on the board of the new UCSF Benioff Children's Hospital, where they have no blacks in the administration, no black who had departments at the Children's Hospital. And when you start to bring it up, it's like, oh, you know, this is like, it's not you're a troublemaker, but it's not an important issue. So my question, and I hope it's relevant, is how do those of us who understand that this is a shrinking the population of opportunities, how do we get this discussion back on the table, back on the agenda of many of the medical schools across this country?
So I think for me, and I think it's a good question, I think that when I think about someplace like UCSF, I am, what gives me hope in that is a Talmadge King becoming the dean of UCSF, someone who understands these issues in a leadership position where he can make change. Yes, he was there as the chair of the Department of Medicine, but now he's the dean of the school. When I think about the work that we do within our institutions, some of the things that come to mind for me is to what extent are we using the outside resources, the community? UCSF is a wonderful example. The diversity of the student body of UCSF came about not because the administration got it. It came about because the staff at UCSF, the people who cleaned and in the kitchen said, we go on strike unless you do something. So sometimes we are trying to do so much by ourselves without engaging others and a wider community and other stakeholders in the process. To what extent are we engaging our boards of directors? When I think about Mass General Hospital and some of its movement in diversity, it made a huge difference that a member of the board of directors then sat on the committee. So as people were sort of giving their comments about how and what they were doing, how they're moving forward, you had somebody from the board of directors saying, you will do something, you will be held accountable. So board of directors, community, other kinds of places, how do we band together? How do we work with people in other institutions to make these kinds of changes? I'm not in any way saying that I think this is easy or that the battle will be over anytime soon. I consider this a part of a continuum of a civil rights battle, and we're at this point in time and the battle will move forward. Part of what I'm putting forward is how do we prepare others to be a part of this, particularly others who are in a generation who may not have the privilege of understanding from whence we came.
Let me just say this, and we're very proud of Talmadge. But the students at UCSF had the largest black student rebellion in this country in the last 10 years because of the conditions in which they felt they found themselves.
Thank you, Dr. Reed. Your visibility, for me, my name is Nkarika Amagwali. I'm a PGY4 Med-Peds at Brown, has been incredible just throughout my career. I have a question, kind of picking it back on the former question. I trained at Hopkins, trained at Meharry, training now at Brown, and I see a lot of value from the different infrastructures that I've been exposed to. And I've oftentimes, now that I'm sort of further along my career, thought about the importance of potentially doing like a sabbatical type program for majority institutions back to HBCU medical schools to understand the population of students and to really add increased value to that system as they apply for residencies throughout the country. I'm just wondering like what your thoughts are for the formation of such sort of sabbatical programs, bringing back people to HBCU medical and dental schools to sort of appreciate as faculty that generation.
So, you know, I think when I talk about this idea of collaboration, that's a part of it. When I think about the value of diversity and the outcome, if you plan to make changes in systems, to make changes in the workforce, and you leave out whole segments in that conversation, then you don't have diversity. Diversity is not just about how a Howard or a Harvard or a UCSF addresses these issues and understands and brings value to our understanding of how we move forward. It's what Morehouse brings to that conversation. It's what Drew brings to the conversation. It all has to be included. When I think about the Commonwealth Fund Fellows, part of the fellowship programs include site visits and has included site visits. And so bringing them to Atlanta and spending time at CDC and the American Cancer Society, but spending time and bringing them to Morehouse so that they can see the quality of programs, the relationship with the community, and understand the richness of what's available from those institutions so that they can move forward. No place can do it by themselves. We have to be able to collaborate. So it may be that kind of program, it may be another kind of program. When I talked about building these networks and communities that you work with, I consider Valerie Montgomery Rice on my speed dial of who I call for advice or how to partner or how to do things together. That's part of what I mean by diversity.
Excuse me, we're going to have time for only one more question, I think maybe over to the left, and we may have time with our panel for additional questions, but we need to get to the next phase of the program.
Yeah, Dr. Reed, I'm Dr. Commodore from Tampa, Florida. I really appreciated that lecture. That was one of the best I've heard. I have a question about the funding of medical schools and the residency programs, and the fact that so much of that is tied to government funding. Yet, I'm just curious, has anyone thought about tying the amount of faculty diversity to the funding that these schools receive? Because sometimes those types of initiatives can cause more change to occur than from the bottom up.
So I can't tell you on that, but I'll tell you on another part that's similar, because I've raised it in lots of meetings. I've raised it in meetings where people have said, did she just say that, and moved back away from the table so they couldn't be near me, so they wouldn't be associated with what I had to say. I think about the research funding that NIH puts out to our institutions for training individuals. While NIH is calling for more diversity, while NIH is saying that we need more leadership and development moving things forward, and institutions and labs get money and don't produce that diversity and don't have people advance and move forward. I think of that in terms of that's taxpayers' dollars, where the institutions who are getting those dollars should be held accountable for what happens to the individuals who get trained, not just the lab. So for me, it would be wonderful. I know NIH is not in charge of it. Wouldn't it be wonderful if 0.5% of the overhead that the institution gets is related to diversity and faculty development? You know, our institutions, they don't respond to a lot of things, but they respond to money.
Absolutely.
And if somebody said part of your overhead is dependent upon how you perform and what happens in this space, they would listen differently. The labs and the professors, I mean, the other part for me, because I'm gonna give you these are my pet peeves. These are my things that, you know, you go home at night and you say, if I could just twitch this a little bit. institutions, when you, for anybody here that's done the grants for the feds and the other kinds of things, and they talk, there's a whole part about the institution and the environment. And you know how many PCRs and other kind of machines and all this other stuff. There's nothing in there that requires you to tell about the environment for how you support your faculty or the career development. And what is the environment around diversity? 1 or 2 lines in there would require something to be written. I can tell you the labs and the faculty who are not paying attention to that, if they thought that some of their funding was dependent upon the answers that were given there, would pay attention differently. This is part of what I'm talking about in terms of how do you use rules, regulations, policies across organizations to have them move in a direction that is towards diversity and inclusion. How can we be more creative so that we're not standing in the door going, please, 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 but we're actually changing how business gets done. Thank you very much.
Thank you very much, Dr. Reede. At this time, I'd like to ask our entire panel to come to the podium and take their places, and then Dr. Lorenzen will introduce our next speaker.
Well, it's a real pleasure for me to introduce the chair of our panel, Dr. Garth Graham. Dr. Graham is actually a professor at the University of Connecticut. He is the president of the Aetna Foundation, and he's responsible for the foundation's philanthropic work, including grant-making strategies to improve the health of people from underserved communities. Dr. Graham previously served as Deputy Assistant Director in the United States Department of Health and Human Services, where he also led the Office of Minority Health. Dr. Graham is a physician, scientist. He's widely published in health disparities, and he is published in the Journal of the American Medical Association and also journals such as Circulation. He holds a medical degree from Yale University, a master's in public health from Yale, and also his bachelor's of science from Florida International University. And as I said before, we're very proud that he is a professor at the University of Connecticut. Dr. Graham.
Thanks, Cato. So my mom always taught me to start everything we do with a word of thanks and praise. And so to start off this whole session, I want to give you the 2 early points, I would say. So one is talking about Joan Reede. So a lot of you know Joan's career, and a lot of you have seen Joan speak and do things, but I believe that Joan has actually changed the trajectory of this discussion around diversity, and I believe that Joan has actually set our country in a new path in a variety of different ways, and I'll illustrate a couple of those things. So one is, I would have never known where Harvard was, or even been to Harvard, if it wasn't for Joan Reede. So the first time I came to Boston on the visiting clerkship program, it was through Joan, and I ended up staying in the Harvard system for about 8 years. And Joan has done a similar kind of career building for hundreds, I would literally say hundreds of medical students and residents and fellows across the country. And we don't take the time that we often should to recognize people when they're here with us. Sometimes we say nice things afterwards. But Joan is here with us, and I want to take this note and time, Joan, to say thank you, not just for what you've done professionally, but what you do personally for all of us. All right. And likewise, you know, when you see folks like Cato and Dr. Morgan and some of these guys who are accomplished in their own clinical realm do this kind of work, they personally behind the scenes are so committed. Cato has provided mentorship for me in a variety of different ways and recommendations and all kinds of different things throughout my career. And it really is where these folks serve not just by words, but by example. And I think it's important for us always to recognize people when they do good things and also call people when they don't do good things, call them on it. But, you know, we have some folks here who are really genuinely committed, and it's important for us to, like I said, recognize them. All right, so let me give you a little bit of background on this whole session that you're here witnessing. Last year I was at NMA, and it was in Hawaii. Thank you, NMA. And while we were all having a good time, I was walking with Joan, and Joan said to me, if I could name 15 of the future leaders, folks, both men and women from African American backgrounds, who I thought were going to be leaders in the future. And she asked me to name 15 of folks who I would consider young talent. And I struggled. I think I got to around 9, Joan, if you remember. And then Joan said, it's a problem that you can't name 15 people. And that in itself is indicative of the challenge that we're facing. I like to consider myself somewhere in that realm. I just turned 40 a couple of months ago, but I guess that's no longer young. But when we were thinking about that whole dynamic and discussion, it reminded me of a friend of mine who is involved in politics and is in the Democratic Congressional Leadership Group, and he said, the future of the Democratic Party is in the future of its young leaders. So I thought to myself at that time when I was having that discussion with Joan, what's the future of leadership in terms of African American medicine if we can't readily identify a pathway, a pipeline, whatever the optics are on who's going to be leading either clinical medicine, public health, policy, administration, whatever you want to define it as. We can't readily see who those people are and help support them and lift them up. Then we face not only challenges now, but we're setting ourselves up for challenges in the future. So hence was born all the momentum with Cato and other folks coming together to bring this group in front of you here today. And I guess because I'm a part of this discussion, I believe this is one of the most important discussions we'll have here at the NMA, talking about pathways to leadership, more importantly, for each of you here and recognizing these folks who are here on the panel, Gail included, who is young at heart, if not young in age as well. Recognizing that we have to support these individuals here and make sure that they continue to succeed because they really are the future, if not the current leadership, from academic to government to policy, et cetera. So moving forward, I hope that what me and Joan talked about back then is having this be the spark for ongoing discussions and initiatives and all kinds of different activities going forward, where we try to build and support the network of young leaders, particularly folks who we believe have the ability as well as the potential to really lead our healthcare system moving forward. And so I'm going to introduce 3 folks here to you today who we think are representative of that. But again, the discussion really is not just about them and their activities, but how do we as an organization, identify and lift and create a network that builds the future of either clinical medicine, policy, or healthcare, in whichever way you want to define it. So quickly, I'll give you the bios of the 3 folks, and I'm really excited about these individuals. The first, Dr. Landry, and really, not only is he a classy dresser, as you can see here, but this guy, I met him first a couple of years ago through the Tour for Diversity activities that he and another physician were doing, where they were bringing young high school students into this issue of talking about science and healthcare, et cetera. And it struck me that he had the ingredients of success, not only in terms of his own clinical acumen, but the ability to have the vision for setting our programs like these to build this pathway in terms of medicine and healthcare, as we've been talking about. And so let me give you a couple of his credentials. He's an emergency medicine physician at Beth Israel. He is a founder of Motivating Pathways. He also holds academic leadership positions at the Disparities Solution Center at Mass General, and then works as well in the Office of Diversity and Community Partnerships at Harvard Medical School. And he's going to talk to us a little bit around the pathway around entrepreneurial leadership and some of the things that he's been doing there as well. Second on our panel, we are very pleased to have Dr. LaQuandra Nesbitt, who is a board-certified family physician and who recently became the director of the DC Department of Health in Washington. And we have to do whatever we all can to support your success in that very, very, very challenging role. That's a very challenging role. But she has already been successful in her career, having previously led the health department in Louisville and done a number of other things, both in Baltimore and other places as well. And she's going to talk to us a little bit about pathways in terms of leadership around health policy and governmental leadership. And then last, in terms of our 3 initial panelists, we're also going to have Dr. Yashika Watkins. And her career has primarily been built around academic academic medicine. She's an assistant professor in the Department of Health Studies in the College of Health Sciences at Chicago State University, and has been doing research and things around colorectal cancer, osteoarthritis, and diabetes. And she's going to talk to us a little bit around pathways to leadership in the academic setting. And after, they're going to make some initial remarks, and then after that, we're going to hear from Gail Christopher, who needs no introduction, so I'll just say Gail. Thank you for being here. Gail has really set the tone for a lot of the discussion we have as a country around race and healthcare and some of the stuff that's been done through the Kellogg, her leadership of the Kellogg Foundation. But really, Grace has been, not Grace, what did I say? Grace? I'm sorry, Gail has been doing amazing things from her prior roles in a number of different settings. And certainly, I think when I first met Gail years ago, I remember our first lunch where she talked a little bit about just about her passion around issues around health disparities. Gail, I think that must have been around 2003. Yeah, it was around 2003, 2002, around 12 or 13 years ago. And one of the things that I think everyone across the country admires Gail for is not just her generic intrinsic passion around these things and the things that she say, but she backs it up in terms of the initiatives that she has both led and supported and the track record that she has built with her own individual career. So I'm honored to really have Gail be a part of everything that we're going to be doing here today. So we'll hear from each of our three panelists, and then allow Gail a couple moments to respond then as well. And then we'll get into a discussion with this group. And one of the things I want you all to do as you hear from all these folks, as well as hear from what Gail is going to say at the end, is not just come up with questions about, things that they should do better, but things that you all can do to help really uplift this whole discussion. So I really want us to really talk about how whoever is going to stand up and talk, I want to hear a little bit how you're going to help us in terms of building this huge new network we want to build around the future of leadership in healthcare and medicine and public health. And so that's the vein of the discussion we want to talk about, is hear a little bit about how things can be done, but then talk about how we help build this as a movement in the future moving forward. So I remember Joan said something to me when I was having a hard time. It was around 2008 or so, and she said, a lot of people can complain, but not a lot of people can do things. And so we want to move this into a discussion not about complaining, but about how we go about doing things. I'm certainly, Joan, in honor of your leadership in the way you do things. All right, so first, I think we'll start off here.
Good afternoon, everyone. All right. I think the first thing I want to say is, as honored as I am to be up here on this panel, I think many of us would have loved to just have Joan continue to field questions from the audience, because she is such a wealth of information, and I know that we all could have benefited from even more time just hearing your thoughts as we try and address our own issues around diversity and leadership, and hearing from your experiences. With that, I'm honored to be here on this panel and try and talk about leadership and where I am in this continuum of leadership, young versus old leadership, established leadership, I guess I should say, and realizing that, I don't necessarily consider myself a leader, and when I started doing the work that I do, I considered doing the right thing, and that has propelled me into a position where I'm up giving talks and giving presentations. And so I guess I am a leader because I'm doing the work that I think I'm most passionate about. And so I want to keep this brief, but there's really 5 things that really sort of come to mind when you think about leadership and developing your own path. And first is, what is your niche? What is your area of interest? And as you develop that area of interest, how do you become an expert in that? And becoming an expert, when you develop that level of expertise, you need to try and work around with the system that you're in to get buy-in for your area of interest. And once you get the buy-in, you need to learn or consider pushing the boundaries and making people a little bit more uncomfortable to continue to move the agenda forward. And I think most importantly in all of this is making sure you have an established network to help support you when the buy-in isn't there or the boundaries that you're trying to push are pushing back on you. So just thinking about my journey and where I'm at, and thinking about the niche that I've tried to carve out for myself, as an emergency physician, when I came into to residency, it was immediately pushed upon me that I needed to figure out what type of emergency physician I was going to be, whether I was going to develop an area of expertise in toxicology or ultrasound, whether I was going to be concerned about issues around stroke or diabetes or other conditions that commonly present to the emergency department. And what I realized is, although I love practicing clinically, there's more to what I want to do outside of clinical medicine. And so I realized that my area of interest wasn't necessarily in what you traditionally think of as, what you think of when you think about advancement in medicine. I was thinking more about how can we diversify the healthcare workforce? How can we promote change so that all patients receive the same quality of care? How do we eliminate those health disparities? How do we make sure that equitable care is given to all of our patients? And that was my area of interest, and that was my niche. And what I realized is there wasn't too many people in the area, in my department, that were even considering this as part of their practice, because they thought we all did it anyways, and this isn't something that we needed to focus on. And also, it wasn't something that was going to lead to career advancement, something that Dr. Reede had mentioned in her slides. And I realized that I needed to push the boundaries, because this is something that I felt most passionate about, and I realized that I wasn't going to be happy as a professional if this is the path that I took for my career, and I needed to make sure that I addressed my true concerns and how I would think that I could do the best for my community. And what I did was I tried to become as much of an expert as possible on these issues. And I will readily admit that I am not an expert, and I can't quote data like Mark Neve, or I don't have the same experiences as Cedric Bright. But I do know what my areas of interest are, and I do know that I'm going to continue to learn and push my own self to making sure that I'm best prepared to answer those tough questions when they come to me. And as I develop that area of expertise, what I've realized is, even though I may not have the fancy title that comes along with some of, with years of experience, I've had individuals come to me because they were looking for advice, because I knew that I was a resource that they could take advantage of to identify for more information. As I developed my area of expertise, I realized the importance of getting buy-in from the individuals around me. And really what it comes down to is thinking about my department in my hospital. So when I was a resident and moved on to junior faculty in my hospital, there really wasn't an effort in addressing diversity, inclusion, and multicultural affairs, and we didn't even have an established office. And one of the things that we did as part of our resident organization is to develop a diversity committee where we talked about the issues that we felt were most pressing to us. And as we talked about these issues, other people started to take notice, and we got buy-in from the institution. And it eventually led to the development of an Office of Multicultural Affairs and then an Office of Diversity. And that office has continued to climb in importance and position in the hospital. And it's something that I'm very proud of, because I remember when there was nothing, and now we have an office that's starting to do the work that we need to address many of the issues that plagues our hospitals. With that, I also developed the Tour for Diversity in Medicine, which was an effort to promote careers in the health professions to underrepresented minorities. And this is something that a colleague and I came up with, because it was an idea that we realized that students weren't necessarily getting the right information, or they weren't getting it in a timely manner. And how can we go about and encourage them to go after careers in the health professions? And what we realized was, when we came up with the idea, we were medical students, and at that time, people didn't take us seriously, because they didn't believe that we had the resources or the skills in order to pull off the task that we had created in the development of the tour. And it wasn't until we had established ourselves in our careers and started to get a little bit of a title, but also started to get more expertise in the matter, that people actually gave us the time of day. And I was very grateful to the Aetna Foundation for sponsoring our first 4 tours and helping us to reach over 1,500 students interested in careers in the health professions. We got a lot of buy-in, and we got a lot of support initially for a number of the projects that we did, but we also got a lot of pushback. And we also realized that the boundaries that we were coming up against weren't going anywhere. And we had to figure out ways to help push those boundaries, to overcome those boundaries, and to help remove those boundaries. And I think that when you think about what's happening in medicine, in order to push the boundaries, you need to be ahead of the curve, and you need to be aware of the changes that are going to happen. it's really important for you to be aware of changes in leadership that are going to be happening in the institution, or those other power plays that come about. And for us, as we developed a number of our projects, we were able to continue to push the boundaries. And we talked about this briefly. A couple of the speakers had mentioned, how do you push the boundaries? How do you get institutional buy-in? Well, when you talk about mandates that are coming down from governmental organizations or governing bodies that help determine where the funds are coming in, when you make the business case for the importance of the work that you're doing, people start to pay attention, and they don't necessarily want to hear it when you just talk about diversity and you talk about we need more blacks and Latinos in positions of leadership. But when you make the business case on how it's going to impact the bottom line, how it's going to impact the institution, how it's going to potentially bring more money into the organization, or how they may be critiqued based on not meeting those metrics, then they start to pay attention. The last comment I want to make, and I'll end, is the importance of a network. And having great mentorship is key for any of the young leaders that are out there. Being able to have someone to look up to turn to when things aren't necessarily going well, or you're trying to figure out what your next move is going to be is important. So having mentorship is important, but then also having peer mentorship and having a collection of individuals who are around you, who are around the same age, same experiences, same academic positions. All of that is important because you come together and you grow as a unit, and you progress as a unit. And my group of peer mentors, now we're instructors and assistant professors, but hopefully in 20, 30 years we'll be the full professors, and we'll be the ones sitting around the big tables in the C-suites making those big decisions. But it's really important for us to have that relationship. I think you also need that support network to make sure that when things go right, you can celebrate your wins, but more importantly, when things go wrong, you have a shoulder to lean on and someone to turn to help you figure out what your next step is going to be. So again, leadership is something that needs to be cultivated. Identifying people who are potential replacements for yourself, I guess, is also something that needs to be considered. And as with the work that I do, I always think about who's coming up behind me and how can I help them along the way. And that's the last component of that network, is making sure that you are helping to train people. And even myself in my more junior position, I still look for the next individuals that I can help build up. With that, I will end my comments and turn it back over to Garth.
Good afternoon. So Garth mentioned earlier that Joan sort of changed the trajectory of this session. She also changed the trajectory of my talking points, which is not uncommon. You come prepared with how you're going to present things, and she always gives you a different or enlightened perspective to sort of think through. And so it's not looking, as one of the slides mentioned, through for a different destination, but looking through a different set of eyes. So I'll sort of share with you in sort of 5 minutes or so, how I arrived to where I am. And a couple weeks ago, I happened to be with a group of women physicians, and someone asked me, how did you kind of end up as a health commissioner? Because I surely didn't walk into medical school. She works at the FDA, saying that I want to work at the FDA someday. And I'm like, yeah, I didn't walk into medical school saying I wanted to be a health commissioner either. And I didn't finish the fellowship that Joan mentioned earlier, saying that I wanted to be a health commissioner either. I also applaud those people who had tremendous clarity knowing that they wanted to go in academic medicine, too, because I didn't have that as well. I was one of those people who, now when I communicate with medical students and people who are in residency, I'm able to articulate it in a much more coherent fashion, that so many of us spend our lives on this sort of academic or educational conveyor belt. You go through K through 12, and then you spend 4 years in college, and you go right into medical school, and then you do a residency, and then you really don't want to grow up then, so you do a fellowship. And so you're speaking to someone at the end of residency or at the end of fellowship, and they ask you, well, what are you going to do? And many of us have this fear of trepidation that whatever we choose to do at that moment will be what we must do for the rest of our lives. And I think that there are a generation of people who are sort of in my group. I'm clinging on to this young thing very well. I like this, being on the panel of young leaders. We hold on to this fear of whatever it is that we commit to or choose choose to do, that's what we're going to have to do for the rest of our lives. And I think we're more so embracing that our next job is just that, our next job, and wanting to be receptive to this fact that we're having a circuitous career path, and wanting to have people be in our support system, or this network that we've talked about a little bit today, who want to help mentor and nurture us, recognizing that we may have a circuitous career path. And what does it mean to be able to manage folks like myself who want to be able to be open to that type of professional trajectory. And so I immediately after fellowship ended up in academic medicine. And so someone who has this health policy bug, who ends up in academic medicine, who I believe negotiated the right contract that should have allowed me to do a lot of good policy work. And when you want to do policy work, policy doesn't move at the same speed of clinical medicine, right? So if you're interacting with a city council or a state legislature and your goal is to be able to do translational research, T2 research, the one paper I wrote that one year I was in academic medicine, you have to be able to be responsive to these policymakers who really want to do the right thing, but don't have that information at their fingertips, and they don't recognize that you've got a slate of 12 or 15 patients in primary care who are waiting for you to come to clinic, or you were just maybe, not me because I negotiated the right contract, on call the night before. And so you have to be in an environment that's supportive enough to recognize the flexibility you need to be in the policy world. And so I quickly recognized that painting the office orange and not having enough flexibility wasn't the type of environment that was going to be befitting for the policy career that I had, and perhaps I needed to try something differently. So after being in academia, I sat down a few months into it and said, what are the types of career experiences I think I need to have to really do whatever it is I want to do on this circuitous career path? And I didn't do that very specific things some people try to convince you to do. Where do you want to be in 3 years? Where do you want to be in 5 years? Where do you want to be in 10 years? I just wrote a bunch of stuff I wanted to do that I would think that at the end of whatever this life is for me, I would have made a difference in this world. And those experiences could come at me in any order, and I just had to be able to be able and ready to receive them, right? They just needed to feel like it was the right thing to do at the right time. And so I sort of set out to get out of this really good contract I had negotiated and in academia and be open to these opportunities to come. And so I was able to get into a sort of a mid-career program that having a really good network of people that I was able to reach out to say, I don't think this academic medicine is a good fit for me. Recognizing this, and this is all in the context, right, I'm going to stay on message, but this is all in the context of what we understand improves health outcomes and helps us to achieve health equity. We know all this can't be done by clinical medicine, right? So we have to have people in places and spaces outside of the clinical medicine realm, and recognizing that we need physicians who are professionally trained and understand what needs to be done for social determinants of health and all of these other things. So I'm making these decisions and recognizing where I need to be planted to have a specific amount of influence in order to end health disparities and achieve health equity. So I get into this career, mid-career program experience, and in about 3 weeks into working at the DC Department of Health, they're like leadership role. So I end up in a senior leadership role in that department. After 2.5 years, I get recruited to go lead the Department of Health in Louisville, Kentucky. And then after 3.5 years there, I get recruited back to lead the Department of Health in DC. And none of these experiences have been without their own challenges. Having a strong network of mentors, two in particular, have been really helpful for me. And one of the things that has been challenging for me is recognizing that there hasn't always been a really good succession plan when it was time for me to leave one role and move into another one. And sometimes that has been my own fault. And sometimes it's not a problem that I've created on my own. I've always had, and sort of to Dr. Landry's point, this philosophy of beginning to mentor right away. So you walk into an organization, you begin to mentor right away. You present at a panel like this, and someone walks up to you and they say, I want to take your job one day. You say, no problem. Email me, let me help you figure out how to do it. And you begin to help nurture that person, not as a way of creating a carbon copy of yourself, but helping them find their best selves. And so I have been fortunate to encounter people who recognize that. I have also been unfortunate to encounter people who have tried to make me carbon copies of them when that's not really what I needed. I needed someone to say how to survive in academic medicine. I needed someone to say how to survive in government, how to not compromise your integrity, how to recognize that being a servant leader and having personal success are not mutually exclusive constructs. So those are the types of things that I think people who are in positions of leadership can recognize and add value to people who are coming after you, and that you need to be able to seek out. If we don't have a great succession plan, all of the good things that organizations like NMA, or all of the great things that you've seeded in your own institutions will fail and flounder. We don't do ourselves any favor by not planting people in our own organizations, by not recognizing what the strengths are in individuals, and then identifying experiences to give to them to make them your replacement. I mean, all of us will move on one day, and we need to make sure that we have people in place behind us. And so I think that the other things that have been extremely important for me is recognizing when we need formal leadership opportunities and when we need to embrace those informal leadership opportunities that we have already had. Sometimes we fear being called a leader, and that is, I think, a really bad thing. This past weekend, I celebrated a 20th reunion of something, and and I had the opportunity to run into someone who reminded me that I worked with him when I was still a college student to start a program, because I'm from about an hour away from Detroit. I'm from a place called Flint. So most people hear only bad things about Flint. So I'm from Flint, Michigan, and I went to University of Michigan in Ann Arbor. And when I was a college student, I recognized that most of the recruitment for diversity came from Detroit. So most of the recruitment that they wanted to do for minority students came from there. They'd bring up busloads of kids. They'd get all of the high grade point average kids they needed from Detroit. Those kids had a great path to scholarships. No one was doing this for my hometown. I called someone and was like, we can figure this out. The first year, they all stayed with kids, my friends, in the dorm. We just figured it out. That program ran for 10 years. 40 students from Flint, Michigan were admitted to U of M as a result of that. I hadn't graduated. So those are the types of things you can do before you are a full professor. Right. Okay? So, I mean, and those are the types of things I think are really important for what it means to become a leader and what it means to be able to recognize future leadership potential. So I'll stop here and then be ready to take questions when we get to that point.
Hi. So my talk today is going to focus first on some challenges or barriers that I feel I've experienced as a public health researcher in academia. And then secondly, it's going to focus on also challenges I've experienced as a public health researcher trying to navigate medicine, okay? So one of the first things I want to talk about is prior to my current faculty position, I had the fortune of having a postdoctoral fellowship. And it was NIH-sponsored postdoctoral fellowship. But one of the biggest challenges I encountered was lack of mentorship. And so what I mean by that is lack of advisement, proper advisement and support. I feel like the two ways that I could have been mentored better is first professional development and career development. And for professional development, for those who are students and for those who are mentors in the room, really mentoring a person not only in research, but taking it beyond research and thinking about career development, asking their mentee, what would you like to do? How can I help you in identifying those resources to help you achieve the career options that you're interested in? Most times in postdoctoral fellowships, most mentees are mentored to go into research. But nowadays, I think mentors need to be open and also mentor people not only to go into research, but into industry, nonprofit, government, and of course, academia. So I just want you guys to keep those things in mind. Additionally, when you think about mentoring, one thing that wasn't done for me that would have been helpful as well is developing someone actually sitting me down and saying, let's develop a mentoring plan, an individualized mentoring plan for me. There are a lot of mentoring template plans out there which should be used strictly as templates, but templates that you take and amend to the person. So amend to really their strengths, their weaknesses, and also really their desires. Secondly, it would have been helpful as well if I had a mentor that would help me identifying those activities, relevant activities that were going to help me achieve my career goals. As Dr. Reede mentioned, a lot of times people are asked to be on committees and you don't know when to say yes, when to say no. And you say yes because you think you should be saying yes. But maybe you really shouldn't get on that committee because it actually is not going to support and help you achieve the goal, for example, of trying to go into industry or trying to go into government. So if someone could have really encouraged me or discouraged me with relevant activities, that would have been helpful. The next one is kind of one that you guys probably all know, but scheduling regular meetings. But what I want to say about that is, even though you may have regular meetings with your mentees, I think the biggest lesson for mentors is figuring out that different mentees need different frequency of meetings. So some mentees need more support, and also the type of meeting that you have with the mentee needs to be different than with another type of mentee. So I'll oftentimes think of mentoring like parenting. So you know when you have a child that needs more support than another child, and you know you need to spend more time with that child. So it's the same in the mentor-mentee relationship. And then the last one is evaluations. So evaluations, not only just informally, if a postdoc is working on a manuscript and you send back comments, but also having some kind of formal record as well. The last thing I want to talk about is challenges as a public health researcher navigating medicine. So I think I'm the only, well, I am the only public health researcher here on this panel that doesn't have an MD. So one of the biggest things I've seen, sometimes not a lot, is this whole notion of intellectual turf. So as a PhD in graduate school, and even for those of you that MDs, when you go to medical school, we all develop these superiority complexes of the way you're trained and your approach is the right way. So I think in trying to work together as collaborators, I think it's best to realize and value that we all have great approaches and ways of looking at things, but also realize the limitations within our discipline of our approaches. And so by realizing and valuing the limitations, I think we'll be able to better develop a collaborative relationship. Thank you.
Let's see. Okay. Good afternoon. I do appreciate your recognizing that I'm young at heart, Dr. Graham, but let me be clear, Medicare cares more about my last birthday than I do. I am not. However, I want to say that I too am honored and privileged and humbled to be part of this critical discussion. We really have to think about what will come next in terms of our continuum of what is indeed a struggle. It is a continuation of the civil rights movement, and more importantly, it's a continuation of the fight for freedom. And we shouldn't lose sight of that. I recently read a book that told the story of the historically black colleges and universities. And and it was the first time I'd ever seen this comprehensive story of how they began and what they accomplished. And the one thing I will say is that every major civil rights leader that we have had has come through from or been affiliated with a historically black college and university. And we need to respect that, and we need to tell that story. And I'll link it to what to me was the common theme in all of our doctors' presentations. Dr. Landry, Dr. Nesbitt, Dr. Watkins, all of your presentations were about the doing. Not about the theory and the philosophy, but about the doing. My mother's motto in life, bless her heart, has always been, make something happen. And I think she really embedded that in me, and I see that in Dr. Reede, I see it in Dr. Graham, and I hear it from all of you. You have internalized this understanding that it is your responsibility to make something happen, to do the right thing, to be involved in action. And lest we get confused, you asked me to talk about how leadership has changed. Our predecessors, they understood that. And they were all about bringing about meaningful change. They didn't get as caught up in the priorities necessarily or the mandates of these institutions that they had been allowed to be a part of. And so I think one of the ways that leadership perspectives have changed is that now that we are in fact included or there is more diversity and we get into these majority institutions, sometimes it is harder to be clear about a mandate to do the right thing and to make something happen. So I'm very honored and pleased, really inspired by what I hear from these young leaders. And my journey in terms of my profession, while I am listed in the program as a PhD, my doctorate is a clinical doctorate. I love the question about osteopathy. Mine is in that field of complementary and alternative medicine. I am licensed as a naturopath, a napropath, and a clinical nutritionist. And it is that clinical background and that holistic understanding that has truly guided my career. When you work with patients directly and you see the inequities and you see the disparities every single day, it is hard, if you are a person of compassion and feeling, not to realize that we have to make something different happen. We have to change the dynamics that our people are experiencing. And that's what I hear and feel from the young people today, and I know that's true of all of you as you work in your clinical practices, in academic medicine, in public health. You, depending on what generation you represent, you have been reminded that the journey is before us. We are not finished. I have been privileged, and it is a position of privilege to be in philanthropy, as Dr. Graham well knows, to be able to make some decisions about directing resources that are catalytic in nature, because that's all philanthropy can do. We don't have the billions that government has, but we have flexible dollars that we can invest in leadership fellowship programs, in community outreach programs, in what we feel might be transformational programs. And for me, and this is the message I want to leave with you, I chose to go to the Kellogg Foundation when I learned that that board of directors had made the decision to become the most effective anti-racist organization they could be. I said, if the 5th largest foundation in the world is serious about addressing racism, then I want to be at that table. And they have invested hundreds of millions of dollars, we have invested as a foundation, in making it okay, essentially, to be explicit about the issue that we are dealing with, which is the belief in a hierarchy of human value. Now that's a nice way of saying racism. Now the tragic events of the last year, which cell phones have helped us to see, are now reflecting the continuation, the evidence of the adherence to this belief in a hierarchy of human value. We're at a moment in time where we don't have to camouflage, I believe, our focus on the need to eradicate this belief. I want to say that again. We can be explicit that the issue we have to deal with is the eradication of the belief in a hierarchy of human value, the eradication of racism. Racism is part of the DNA of this country. And those of us who understand epigenetics, we know that whether the genome expresses as the phenome is about the conditions that we create. And so while racism is part of the DNA of America, we can push for conditions that do not allow that to be fully expressed, to continue to be expressed in our society in the inequities that we see on a daily basis. And so my recommendation for the young people on this panel, for all of us, is not to lose this moment. We have a moment that I haven't seen in my lifetime to stand up and say that racism must end in this country in all its forms. So I encourage you, thank you. I encourage you to listen and to seize the moment, because as those of us who've lived long enough to have Medicare smile at us, we know that this moment may not come again for another 50 years. But this is our moment to stand together and embrace the possibility of truly eradicating inequities in all of the spheres, but most importantly, because racism gets under the skin and it creates pathology, to eradicate the effects of racism in terms of health inequities. Thank you.
Okay. You know, I had to miss 11 a.m. service to catch the flight to get here today. Every time I hear Gail speak, in the back of my mind, all I'm saying is amen. Amen. Because Gail, I think she's exactly right. And I think we should give Gail a hand just for a totally moving series of points. Absolutely. It's an interesting time. Okay, so here we're going to go. We're going to go now to our questions and answers. And I would like us to really, stay focused on this issue of what can we all collectively do to help build this cadre of young leaders, build this network, so that we can lift folks up, as Gail pointed out, at this key point in our country's history. And I see Kamara and others there, and just recognizing their leadership and things that they have done as well. So why don't we start here and then go over here and then back.
Well, again, I'm Dr. Richard Smith. I'm one of the vice presidents at Henry Ford Hospital, one who's sponsoring this event here today. I'm a longtime member of the NMA. In fact, they gave me one of those old-time badges. I think they gave me the wrong one. They said 40 years. I thought that was a little bit unusual, that sort of thing. I'm also the past president of the Michigan State Medical Society as well. I enjoyed your comments. I particularly enjoyed your comments. I think they were exceptional. The Kellogg Foundation is in Battle Creek, and in Battle Creek, Michigan, there's a highway that runs through Battle Creek, and it's called the Sojourner Truth Highway. State of fact. Sojourner Truth. That's the basis for where Kellogg and where they come from. To give you an idea, it symbolizes our connection to the Underground Railroad, which was the first civil rights movement that existed in this country, which existed right here in Detroit. You guys have looked out across the river right through there? That's Canada. That's right. That's freedom. That's right. That's freedom. Before they get there, they had to come to Detroit. They did. They had to come to Detroit. And it was through a nucleus of leaders, young leaders, who did all that stuff. They took the risk. They took the organization and they funded the organization in order not 100, not 200, not 300 fugitive slaves like Sojourner Truth or from Harriet Tubman, but 50,000 of them came to Detroit, went across that river, sat by the casino where there was an old barracks by the British, where they got a field hospital to take care of them before they established communities in Chatham and other places, Buxton, all right across the river. That was the original one, and it had its basis in healthcare as well. So I appreciate your comments and all the great things that your organization has been doing. I enjoyed your comments too. I'm a Go Blue person as well. And I'm a child of BAM, if you understand what I'm talking about. Yes. That stays with us. We don't have to say anything else, but you understand what I'm talking about. That's correct. Another movement of students, young students, leaders who went ahead and opened the doors. The word was open it up or shut it down. And they opened it up not for Michigan, but then to the Big Ten, but then through the United States. That's what occurred at Michigan, and they're still fighting that fight there. But it took young student leaders. This is a room full of leaders. All of us are leaders here. That's why we're here. We're listening how to get better. And the mentoring that you talked about is very important too. The question I have is this. We've done a lot of stuff in these 40 years. But when you say, hey, listen, we got a position on the March of Dimes board. You want to do it? Doc, I ain't got time for that. You know, I play tennis on there. I got a golf game coming up. I don't have time for that. We got a position on the mortality board at the state of Michigan. You want to do that? Well, Doc, I'm going to Vegas this weekend. I can't do all that. We got the National Medical Association in Detroit. Are you coming down? Oh, no, I don't have time for that. It's just a bunch of old doctors. How do we reach out to a younger generation of people to give them that inspiration? We don't need it here. We're here listening to you. What do you do to inspire your young leaders or young physicians, particularly to say, this is now your turn to lead? That's my question.
So I'll address the board issue because I have the opportunity to appoint people to boards. I don't find a problem recruiting young physicians to boards. What I have found is that people who are in my position who have the opportunity to appoint young physicians to boards don't start with them or provide them the opportunity. They are trying to always look for the person who has 25, 30, 40 years of experience in the field to be on the board. What I have tried to champion, especially for boards that are working boards that need to issue reports, that need to have policy positions, is trying to express to people that you need some members of your board who can do the work of the board. And the people who will do that are young physicians who are still trying to advance their careers. And I believe if there were more people who, when they are being asked to serve on boards, who, and because I like to be frank, so I think we can do that in this room. There are people who accept seats on boards who don't actively participate. And they are those 25 and 30-year-old career folk who just simply show up to the quarterly meetings, don't do any work in between, and have to get into the position of passing that baton, freeing up that space to a more junior person who would actually participate actively in those experiences. So I do think that there are opportunities for people. Now, what does that mean? Young physicians are not going to continuously show up where they don't have any authority and any responsibility. They may be finding those opportunities in other places other than the NMA. They may be finding them in their specialty organizations. They may be finding them in their institutions where they may not be advancing as quickly and then eventually just give up on it altogether and no longer be categorized as young physicians. But they are not going to consistently show up in places and spaces where they are never going to be given an opportunity to have any authority or any responsibility.
The only thing I would add to that, I 100% agree with the comments you made about the leadership. The one thing I would add is, as young physicians are coming out and they're becoming more established in their careers, there's conversations like this about how to become a leader, how to manage an organization. Conversations like this need to happen, and having more of a curriculum focus around these type of conversations would be beneficial to the younger professionals that are out there, because I think a lot of the information that they're getting specific to their practice or their field is coming from the specialty organization. So you have to come up with a different curriculum that's going to be more enticing for those younger physicians to come out and participate in the NMA.
You know, that's such a good point. I'll just interject. I was at my subspecialty organization meeting a couple of months ago, and I mentioned the NMA meeting coming up to the younger group, or whatever you call it, the young council, or whatever it's we call it, and no one was coming because they just didn't think it was relevant to what they were doing. And so I think there's some real challenges that we face in terms of creating spaces that people feel energized and relevant around. But sir.
Thank you very much. And again, I congratulate all of you for an excellent job on this panel, and it's certainly wonderful to have heard Joan's wonderful remarks earlier. But this is my 42nd year in the NMA. My first NMA meeting was in 1973. And I was, while listening to your presentations, thinking about what advice would I have given to that guy who attended that meeting in that year, or what advice would I now have, or what I would have given to my 40-year-old self. You guys are plus minus that age, and what would I have done differently in the years since then until now. And so, in thinking about your next steps, and you should be doing that, the day you get your current job is the day you should be thinking about what your next job is going to be, because everything you do in your current job will lead you to whatever that next role will be. I would tell my 40-year-old self to be more gregarious. It goes back to something that Joan said. The people that are going to make decisions about you want to feel connected to you, and sometimes we undervalue that informal social connections. I got invited to play golf so many times that I can't even remember, and I never took anybody up on it. I got invited to parties. I got invited to those social events that allow people to understand who you are as a person, a bit more comfortable with you as a person, as opposed to your role as a physician or a leader. And that social connection, which Joan was talking about with respect to who gets promoted on faculties, is that sort of nebulous but very important component that allows people to then recommend you or think about you when considering who's going to take over for X, Y, and Z. So my advice to you is not necessarily learn how to play golf, but take advantage of those opportunities to meet informally with people, to get to know them a little bit. That's what I would have told my 40-year-old self, and if I had followed that advice, who knows, I might have actually got a few more things done. Thank you very much.
Before you go, tell folks a little bit about the things that you did get done. I think your advice is relevant, but more importantly, coming from all the vast array of experiences you had and are currently having.
I don't really wish to take, I mean, there's questioners at the line here that have I've done a lot of different things in my career. I've been involved in a lot of different leadership roles in medicine, public health, and politics, and a whole variety of things. And I think in all of those areas consistently, if I could have taken that just with one extra step, who knows what else I would have been able to accomplish. But it's a journey, and you got to enjoy it. But you got to get out there, and even though you don't necessarily want to go to that luncheon, or even though you don't necessarily want to get up for that breakfast, or even though you don't necessarily want to get up on that and take that early morning flight, that's what I would tell you you've got to do. You got to get on the airplane, you got to go to the luncheon, you got to go to the breakfast, you got to go to the meeting, you got to show up. And when you show up and people see that you care and they get to know you as a person, that's when all kinds of doors will open up for you that I think will lead you to your next adventure, your next journey, and all of you have incredible adventures and journeys awaiting you, and I just wish you all the best.
I would just like to reinforce, we have this saying among peers in the foundation, we say the relationship is primary and all else is derivative. Now, in the world of racial hierarchy that we're still functioning in, as Dr. Reed's data showed us so clearly, people still have to vouch for us. And so once again, those relationships, not only with our peers who are African American or are, quote, minority, but those relationships across lines are absolutely critical for that person informally to vouch for us when the decisions are being made about who gets the promotion or who gets the job. So I really appreciate your point. I think it's extremely valid.
Very good point. And though I don't want to underestimate the doors you have opened and the things you have accomplished in your career from the state level to the corporate world to everything that you're continuing to do. So I wanted to thank you for everything that you've done. Kamara, please.
Yes, I want to lift up Dr. Gail Christopher for the clarity that you continue to have about racism and the importance of us naming and addressing racism as a threat to the health and well-being of the nation, and to observe that for young people, maybe we haven't done our job in terms of teaching history or whatever. I had a very interesting conversation with a 35-year-old colleague who said, oh my God, her mind was blown with all of these, you know, now the cell phone and body cam photos, and now, you know, in the Black Lives Matter movement, and this was their time, and they thought that the civil rights movement had solved everything. And I'm looking at her and I'm like, oh, we did not do a good job. We did not do a good job if she thought at 35 that everything was okay. Now that means, of course, that she came from a certain social segment where opportunities had opened up for her. It means that she, along with others who thought that the election of President Obama meant the elimination of racism, I mean, she was in that, but now she knows. But what I want to say is, I know that many in your generation think you know your brilliance, and you think that you got where you are because of your brilliance, not realizing that there have been centuries of brilliant people in this country who could not get anywhere, and that we are standing, and you are standing on the shoulders of others. You need to stand tall, as all of you said, so that others can stand on your shoulders. You need to reach back, but also don't be blinded to the reality that racism is very alive and well in this society, and this is the core thing that we need to do because it is a threat to the health and well-being of the nation. So I want to thank you for your clarity and for your infusion of thought and funding and all in this, and I want to ask you guys, like, did you know that? Or when did you learn it? Or what? I want to hear from you. Are you like my 35-year-old colleague who is surprised, or what?
I'm from Flint, Michigan.
Oh.
Keeping it real.
So that's going to be my brief comment. I got it.
So for me, my parents grew up in segregated Texas, and I heard stories about how my dad recounts the first time he saw a white person, and he was 10, and he talks about the experiences he had in college at the school he went to. My mom talks about her experiences. So I've had this exposure for a while, and then you said you went to Flint. I went to Prairie View A&M University. And this type of discussion is a part of the culture at Prairie View, and so I've been exposed to this discussion about race and opportunities because of race or lack thereof, and then also the importance of having strong leaders coming from communities, especially like you mentioned the HBCUs, because of they've opened so many doors for students like myself. So this is not something that is new to me, certainly not an eye-opener. It's just a continuance of the disappointment of the non-continuous progress that we've had in this country.
So I was born and raised in the South and went to HBCU in the South, so I'm well aware of the problems.
But I'll elaborate a little bit on that because I've actually worked in two different types of urban communities where the leadership of those communities have looked different. And so where policy decisions are being made, I can speak to where there is a clear manifestation of people not having this type of experience, or where you can actually see that there are people in this 25 to 35-year-old space who don't really have an appreciation for differences in opportunities, and not necessarily just related to race, but also related to classism, and not being able to have an appreciation for what variation in social class has done among racial and ethnic minorities. And so because of that, there is this constant need to have this conversation about the impact on race and ethnicity and the impact of class in a very overt way on health. And so it has become a responsibility in these roles, as part of my thing is to close the chasm between clinical medicine and public health, right, and talk about this larger construct of population medicine and population health, and having this big opportunity with all that's changing, right, with healthcare reform and health reform, and taking advantage of this opportunity that may never present itself again. But if we don't put these issues on the forefront of people's minds, that it's not just about universal access for people who we could pretend as if we've blinded ourselves to these issues of race and class, everybody's going to shake out on the same side on the end. I constantly use this slide about the differences between equality and equity. And people get very comfortable with equality, but not so much when we have to start talking about equity. So we do have this responsibility, and I make the Flint, Michigan comment tongue-in-cheek because I think people look at my credentials and everything and have this, they forget, you know, I'm a blue-collar kid. My parents worked for GM and retired. All three of my sisters and I have doctoral degrees, and so they don't necessarily have an appreciation that I would understand these things, but it's part of what drives me to do the work. So you asked a very real question, is that why the three of us are here? It very well may be. And do people think that their brilliance is why they got here? I don't know that that's a universal yes, but I do think that if we begin to accept that as the answer, we could find ourselves in a very dangerous place in the future.
Thank you. I'm sorry, say that again? Well said, exactly. Very nicely done. So here's the time check. We are almost at the time where we'd end the session. I would like to ask for permission to go for 10 minutes more. I wanted to be explicit in asking for that permission because I think we have a lot of good energy that I don't want to dissipate, and then spend the last minute or two talking through what I would like to see in terms of some potential next steps from this group. So given that we have 12 minutes or so, I'm going to ask you all to do comment or question, to keep it to about a minute or two so we can get everybody that's up here and then kind of close appropriately. Is that reasonable? Okay. Okay, thank you. Please, ma'am.
Okay, my name is Stacy Hunt, and I'm actually a native of Detroit, and I now practice at Kaiser Permanente in Northern California. And one of the things that I just wanted to mention, because, you know, talking about hard work, is that, you know, I really felt like once I had finished medical school and had done all the hard work, that would really get me to where I wanted to go in my career. And what I found out after a time is that it was those unconscious biases that really kept me from reaching a lot of my goals that I had, and that we weren't taught that when I was in medical school. So one of the things that I would like to even comment on is that maybe we should, you know, think about having some of that information passed to the medical students and the residents, because a lot of times, a lot of us, like myself and my husband, we're first-generation physicians, so we didn't have those mentors to really talk to. So we really began to run into the glass ceiling for so many different reasons, and it wasn't because we didn't have the integrity or the education. It was just because that glass ceiling was there, and there were a lot of unconscious biases. And really teaching, and I've seen a lot of people leave the organization not because they couldn't do the work, but because there were other things that stood in their way of being successful.
Thank you.
I'm an internal medicine physician in DC, trained in health policy, and I serve on the Medicaid Pharmacy Committee for your sister agency, Healthcare Finance, and also vice chair of the Health Information Exchange for your sister agency, having a little trouble getting into your agency. But I think a more important question is, DC has been driving out physicians from local government. They're no longer in your departments or the sister department to a great degree that it used to be before. So we're delighted to have you there. But I guess I'm curious as to how you, with all the busyness you have at being at the cabinet level for the mayor, how are you building contacts with local physicians and other community health folks so that you've got a support structure that's helping you accomplish the things that you want to accomplish?
So I'm on a talent acquisition plan. I actually have 4 or 5 physicians now in my department in senior leadership roles since I came back in January, and growing. So I endeavor to resolve the issue that you have just described, and I'm working with my sister agency, Healthcare Finance, to help them increase at their agency as well. So duly noted.
Excellent answer.
Thank you.
Yeah, and I think going back to what I said earlier, we want to make sure that what we do here is discuss how we can help you and kind of help lift up all the roles in terms of everyone here today. So please.
Good afternoon. My name is Rhonda Maddox, and I am a psychiatrist and the medical director for the Arkansas Minority Health Commission. As we've talked a lot about mentorship in advancing our careers, I will say that my mentorship has come, many times from African Americans, but some of the critical advancement that's happened because of my mentorship has actually come from white females. I recall as a third-year medical student being asked by one of my attendings about my experience with sexism, and that kind of baffled me, because when I had negative experiences with senior attendings, it never occurred to me that it was sexism or ageism or anything. I just thought of it as racism. And so as we started to have the discussion about what that would even look like, because it had just never entered my mind, I remember her having talking to a senior psychiatry resident who was calling all the women girls. And she had this conversation, and so what she said to me was, she talked about how they would, to call different one doctor, but when they talked to women, they would say Rhonda. And so I had never noticed that. I just thought maybe they were calling me by my first name because we were familiar. And so my question, it's to the women. Sorry, guys, okay. But even on so now when I'm astutely aware, or keenly aware when I'm in an audience and all of the men are referred to as doctor and the women are referred to by their first names, when that situation happens, I do not want to be considered an angry black woman, and so I try to figure out how to navigate that terrain. Sometimes I do it in a sarcastic way, sometimes I do it in a very joking way, but how have you navigated that terrain when that happens? And obviously everyone else is being recognized, sometimes very unconsciously, and in other times it is to discredit what you've done. What do you do?
So I actually want to address that because I deal with that actually weekly at work. In the department that I'm in, it's not, it's mostly it's mostly blacks, but it's blacks from other countries, and some of the men have ideas that women should do more secretarial or administrative things. So when we're in faculty meetings, they oftentimes look at the women in the room and turn to us and ask us to take notes if the chair's assistant is available. Any tasks that we come up with regards to whether it's accreditation or anything related to research or students, they turn and look at the women. So one of the things I found myself doing is in a very polite way reminding them that they are being sexist and saying that there needs, equally we need to take responsibility of tasks. So it's annoying and frustrating to deal with that. Like I said, I deal with it weekly, but it's a reality.
I would just say that sexism is real. It's part of the hierarchy of human value that we inherited from the 17th and 18th century. One of my most effective interventions in that space was, if you're a woman and you make a comment, often it will be repeated by some man in the room, and then all the men in the room will say, as John said, whereas you had just said it, but it was ignored, right? And so what I found myself doing at a very high-level meeting one time was just to say, excuse me, is there an echo in this room, or did I not just say that? And it was like immediately from that point on, because this was a commission that I was going to be a part of for a couple of years, after that, it never happened again. And so I share that story to say that part of what, as you said so eloquently, what you have to do is you have to call it, and you have to graciously stand up for who you are, and usually you get more respect as a result of having done that. And not necessarily as an angry black woman, but as a woman who has clear boundaries and has a deep understanding of who she is.
Nicely said. All right, so we're officially 4 minutes over, and so we have room for 1, 2, 3, 4, 5 more comments at 1.5 minutes each.
Okay. Hello.
I just came up with that random math. I have no idea.
I'll keep it short, I promise.
Don't stick to it. Just do what you want.
Hi, Victoria Golston here from Detroit, Michigan. I want to thank all the panelists for all your insight. It was greatly appreciated and really informative. My specific question is for Dr. Nesbitt. I'm interested in the kind of environment that you are facing, assuming your new position at the DOH, and some of the limitations that you're currently dealing with.
So it's an interesting question. It's a political appointment, so I had the choice to take the job. And had the opportunity to be interviewed and sort of interview at the same time for the leader that I would be working with to make sure that our ideals and philosophies were aligned. So I don't feel as if I'm working, sort of a square peg in a round hole or trying to work for a political figure for whom they don't sort of share the same views and perspectives that I do in terms of health policy and public health. That being said, everyone's a politician where I work, and everyone shows up to hearings. I have had hearings where there have been 72 public witnesses, and they don't always understand the public health or healthcare perspective or incentive for doing something. And this speaks to the question that was asked earlier in terms of if you don't have a team of people who are professionally trained in the field, and not just physicians, but public health professionals, and how that is broadly defined, if you're not using data to inform your position, and if you don't speak with a level of confidence and show up to hearings being able to have an informed position on an issue, you will get run over immediately. And so in the first 6 months, I think I've had 8 hearings. The first 2 weeks of July, I had 4 right before council went on recess. And so you have to have a team that's able to help inform that policy position so you don't get caught flat-footed. So it's very rapid fire. You have to be data-driven. You have to be able to have a collaborative approach working with council members who are maybe getting a lot of pressure from constituents that don't necessarily understand what the right things are to do. And some things that happen nationally or in other jurisdictions may not be a good fit for you locally. You have to be able to articulate that in a way that makes sense. So I don't have a disconnect from my superior leadership, but there's also this being able to manage and engage relationships at the community level. And you never have the balance of the people who support your position showing up in the same numbers as the people who oppose your position. So that's just par for the course. Yeah.
Thank you.
Thank you.
Great. Good afternoon. Kimberly Dawn Wisdom, Senior Vice President of Community Health and Equity and the Chief Wellness and Diversity Officer at Henry Ford Health System. Really enjoyed the panel very much, and I want to thank Gail Christopher from Kellogg for all the support that their foundation has given related to childhood obesity across the state, as well as infant mortality reduction in the city of Detroit. But a very quick question, and I hope it's fairly provocative in terms of leadership and addressing the reduction and ultimate elimination of racial and ethnic health disparities, and it's related to another provider type. I have individuals coming to me, probably 100 a year, wanting to be mentored, talk to me about career paths and combining medicine and public health. And there is a great need, of course, for positions to help drive the elimination of disparities. So the notion of, and several of us are working on this across the country, of having state-level surgeon generals in every state and territory to help drive down systematically the elimination of racial and ethnic health disparities, and close that gap and have some accountability around that. So I just like the panel as much as you can to address that type of position, and it would create more capacity for leadership positions for our upcoming young people, and it will also systematically help us drive down the elimination of racial and ethnic health disparities. Thank you.
I mean, it sounds like a great concept. I think you have to have buy-in from the state leadership in order to establish this position. I think you have to have a clear understanding of what their role is and how it interacts with the other parts of the government and making sure that they are able to do what they need to do, and you're not just putting someone there as a figurehead and allowing them to actually have power and money in order to enact those changes.
Yeah, and I think part of what we are sort of revamping or recreating our identity in with the DC department and the rebranding, I guess I'll say, in Louisville is what is the role even of a health commissioner or a health officer, right? A lot of times you get pigeonholed into this, you're a bureaucrat who operates a state agency, and no one really looks at you from the perspective of influencing policy and setting a health agenda to advance, you know, the health status of a community. You're sort of looked at as a social service agency. And so I've kind of walk around with this moniker, we're more than healthcare for poor people, and making sure that people understand that it's not being meant in a disparaging way where we need to be the healthcare safety net. We absolutely will, but there's so much more we do for a community than that, and there's so much more that we advise the health policy makers or the policy makers in general in the jurisdictions that we work for, or we should be doing from my perspective, or why I take the jobs I take at least. So it then begs the question of, do we need to have a revisiting, and I know we do this in some of our health officials meetings, do we need to have a revisiting of what the role of health officers are in our communities or at our state level, or a creation of this new position and role? So I'll just leave it there.
Thank you. And unfortunately, guys, we're going to have to cut it off here, as Cato just let me know there's another session that is concurrently starting that we all need to be a part of. So, you know, clearly evident by the fact that you all stayed and folks lined up and the energy in this session, there's a tremendous need for these kinds of activities. And so what I want to leave you here is a plan that we started out with at the beginning, which is kind of twofold. One, I start off by recognizing all of the folks that have kind of built the track that a lot of these folks are running fast on. And we want to make sure that we can connect all of you into a network that can help lift up other young folks. So there's a lot of great leaders in this room right now. You saw Woody earlier. You know, Georges is here, who runs the American Public Health Association. Kamara, who has been writing and doing research and building all of the blocks that we know and talk about when we talk about racism and healthcare, and all these different folks. And what I want to talk about is just the fact that we want to connect the folks that we think should be connected to all of the folks that have the power and influence to help elevate their careers and kind of keep things moving. That's one of the things that I think is important, is creating a network for the future leaders based to a large extent on the accomplishments of folks who have done many things in the past. So that being said and done, you'll hear from us in the future. It's an idea that I think Joan and I have been percolating and working on. And we ask that if you really are committed to this issue of building a pipeline, that you stay committed with us and help create opportunities for a lot of the future leaders who need those opportunities. Cato, I'm gone. Go ahead. Take it over.
Well, thanks. I'm just going to take 2 minutes and close. First of all, I want to thank the panel for just a fantastic presentation. Just really wonderful. And I want to again reiterate my thanks to all who have been involved in this program. It's just been a fantastic program. It was started by Dr. Joan Reede, who just gave an incredible Cobb Lecturer, and the tradition of W. Montague Cobb. Thank you so much. And just as a couple things, we're being respectful to the postgraduate section. They've already started their poster session at the exhibit hall, so we want to be there from 6:30 to 8, and then they have the 4:30 to 6, and they have a reception. We also have our Cobb Institute reception, which starts at 6:30 to 8 at the exhibit hall 2 at beyond the NMA Central at 6:30 to 8:30, and it's going to be a great time to network with the Cobb Senior Fellows and other individuals at the Cobb Institute. Should be a great time. And we, in terms of next steps, we have already talked about in the Cobb, we're going to be voting, our board will be voting tomorrow morning to institute our new class of individuals in terms of the Cobb family. It's going to be the Cobb Scholars. It's going to be a group of individuals to really address what's going on in the pipeline in terms of individuals with interest in minority health and health disparities. We'll begin that as a new group. It's going to be a multidisciplinary group, not just physicians, but also dentists, social workers, pharmacists, all those that are interested. It's going to be a new community of young people, young described as anyone 2 years old, 2 years younger than you are. And so of young people who will be involved in it. So we hope to announce the Cobb Scholars as really a multidisciplinary group of individuals that will be there. We're also interested in creating a network of scientists who are working something likened to, and we just started to talk about this, likened to the, as we know, there's a Howard Hughes Medical Institute, and throughout the country there are these Howard Hughes Medical Institute professors. We're thinking about doing the same thing in terms of the area of health disparities and create W. Montague Cobb Institute professors who will be across different universities, mainly young faculty members, to create a network of individuals working in health disparities and also create this virtual network of faculty who can work on projects in conjunction with the Cobb Institute. So you'll hear about that soon. But again, thank you so much for being here, and we welcome you to come to the reception later. Thank you very much. Great job. Thank you.